Welcome to the Radiology Review podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome back to the Radiology Review podcast, your on-the-go source for radiology board review. On this episode, I will continue our discussion of head and neck cancers for radiology board preparation in a question and answer format. I will post a free downloadable study guide, as I do for most of my podcast episodes, that you can access on my website, www.theradiologyreview.com, that I will make available once I have released these episodes on head and neck cancers. Without further ado, let's get into the questions and answers for part 2 of my review of head and neck cancers. First question: what is the most common salivary gland tumor? The answer here is that a pleomorphic adenoma, which is also termed at times a benign mixed tumor, is the most common salivary gland tumor. This is most commonly located in the parotid gland, and nearly all of these would be seen in the superficial lobe of the parotid gland. But a pleomorphic adenoma can also occur in the submandibular or sublingual glands. Pleomorphic adenomas tend to be very T2 bright. Next question: what is the second most common salivary gland tumor? The answer here is a Werthams tumor, Warthins, Werthams tumor. You do need to know when you take the ABR core exam that a pleomorphic adenoma is the most common salivary gland tumor, whereas the second most common salivary gland tumor is a Werthams tumor. A Werthams tumor is typically only seen in the parotid gland, unlike a pleomorphic adenoma that could also be seen in the submandibular or sublingual gland. And importantly, for board review purposes, Werthams tumors may be bilateral in about 15% of cases. A common theme for board review questions is the differentiation between pleomorphic adenomas and a Werthams tumor, so make sure that you have those down. And that leads us to the next question. If you see a parotid gland tumor that shows uptake with technetium-99m pertechnetate, is this most likely a Werthams tumor or a pleomorphic adenoma? The answer is a Werthams tumor. Okay, Werthams tumors would show uptake with technetium pertechnetate, whereas pleomorphic adenomas typically wouldn't. A mental trick that helps me remember this is war tech, like war technology, to help me remember that war, W-A-R, a Werthams tumor, has uptake on technetium pertechnetate, war tech. I don't know if that works for you, but it does for me. Next question: what is the most common malignant tumor of the minor salivary glands? The answer is that a mucoepidermoid carcinoma is the most common malignant tumor of the minor salivary glands. A mucoepidermoid carcinoma also has an association with prior radiation to the head and neck, and that leads us to the next question. Are malignant tumors more common in the smaller or larger salivary glands? If you think about some of the questions we've already discussed in this episode, it could lead you to conclude correctly that malignant tumors are more common in the smaller salivary glands, and benign tumors are more common in the larger salivary glands, which typically means the parotid gland. The smaller the salivary gland, the more likely that a tumor involving the gland may be malignant, but this is not a definite rule. Remember, I told you previously that a pleomorphic adenoma can be seen in the submandibular or sublingual glands, although most common in the parotid gland. And we also just reviewed that the most common malignant tumor of the minor salivary glands is a mucoepidermoid carcinoma. In general, the smaller the salivary gland, the more likely that a tumor involving the gland may be malignant, and that rule generally may lead you in the right direction on board review questions. Next, for board exams, what is the most important finding that is associated with adenoid cystic carcinoma of the head and neck? The answer I am looking for here is perineural spread. When you think adenoid cystic carcinoma of the head and neck, you should next think of perineural spread. That should almost be a knee-jerk reaction, okay? Adenoid cystic carcinoma of the head and neck equals perineural spread. Next, if you are shown images of the head and neck that demonstrate a honeycombed appearance of both parotid glands with bilateral parotid masses that are found to be lymphoma, what is the most likely underlying disease state that this patient has? The answer I am looking for here is Sjogren's syndrome. And this is important because Sjogren's syndrome has a markedly increased risk of lymphoma of the parotid glands. Note that parotid lymphoma may be primary because the parotid has internal lymph nodes, or secondary. A differential consideration for something that can look like masses within diffusely abnormal parotid glands that may have prominent cystic change is HIV benign lymphoepithelial disease of the parotid. So I would really keep those two things in mind for diffusely abnormal appearance of the parotid glands and possible mass-like areas within the parotid glands, either Sjogren's disease with potential lymphoma or benign lymphoepithelial disease related to HIV. Next, and this is a bonus question, not pertaining to masses, but still pertinent to the anatomy we're talking about. Which salivary gland is the Stenson's duct associated with, and which salivary gland is the Wharton's duct associated with? And that is Stenson, Stensen, and Wharton, Wharton. The answer is that the Stenson's duct is associated with the parotid gland, and the Wharton's duct is associated with the sublingual gland. Next, if you are presented with enlarged lymph nodes in the carotid space, what is the number one differential consideration? Squamous cell carcinoma nodal metastatic disease should be the top consideration whenever you see enlarged lymph nodes in the carotid space. We will talk more about the carotid space on future episodes. For now, I'll leave it at that. Next, a head and neck mass that demonstrates the classic salt and pepper appearance on MRI should make you think of which entity first. The answer is a paraganglioma. The classic salt and pepper appearance of a paraganglioma results from a highly vascular mass that contains foci of hemorrhage internally. The dark areas, the so-called pepper, result from phlovoids from the high vascularity, and the bright areas, the so-called salt, results from internal hemorrhage within the mass. So salt and pepper appearance, that is most typical for a paraganglioma. Next, paragangliomas classically light up on which nuclear medicine exam? The answer I am looking for here, similar to an esthesioneuroblastoma as we reviewed on the previous episode, is that indium-111 octreotide would classically light up a paraganglioma due to presence of somatostatin receptors within paragangliomas, and by extension, you would also expect to see uptake on a gallium-68 dotatate PET-CT examination as well because of those somatostatin receptors. Next question. Can you name the principal tumors of the head and neck region that are considered to be paragangliomas? There are several different types of head and neck paragangliomas. Can you name at least some of these? The answer, in no particular order, is a carotid body tumor, Glomus Jugulari, Glomus Figalli, Glomus tympanicum. Okay? Note that a pheochromocytoma is also considered a paraganglioma, but it is classic for the adrenal glands, obviously, instead of a head and neck primary mass. As an additional point, a Glomus jugulotympanicum also technically exists when a Glomus jugulari involves the middle ear cavity, but that is perhaps extra credit level knowledge. And the primary masses I think you should be aware of for the ABR core exam include carotid body tumor, Glomus jugulari, Glomus Figalli, and Glomus tympanicum for your head and neck paragangliomas. Next, what is a classic imaging feature of a carotid body tumor? For each of these paragangliomas, you need to know a few classic features that can help you differentiate these on board exam questions. So let's start with the carotid body tumor. The answer is that carotid body tumors classically present as a mass at the carotid bifurcation that splays the internal carotid artery and external carotid artery away from each other. So one more time, a mass at the carotid bifurcation that splays the internal carotid artery and external carotid artery is most typical for a carotid body tumor. Also look for that potential salt and pepper appearance to help you out. Next, what is a classic imaging feature of a Glomus Jugulari? A Glomus Jugulari classically presents as a skull-based mass with osseous destruction of the jugular foramen. So carotid body tumor would be expected at the carotid bifurcation. A Glomus Jugulari would be expected at the skull base, and you would classically be shown some osseous destruction of the jugular foramen from the adjacent Glomus Jugulari. Next, what is a classic imaging feature of a Glomus Figalli? This one is a little harder for me, but a Glomus Figalli classically presents as a mass between the carotid bifurcation and the jugular foramen. Now, unlike a carotid body tumor, this is often, at least on board exams, not a mass directly at the bifurcation, but it would more typically be located deep to the carotid arteries and in front or superficial to the internal jugular vein. A carotid body tumor will splay the ICA and ECA apart. A Glomus Figalli tumor will push both the ICA and ECA forward and the internal jugular vein back. Or in other words, it would push the ICA/ECA more superficial, and it would push the internal jugular vein more deep into the neck. That is a Glomus Figalli. Next, what is a classic imaging feature of a Glomus tympanicum? The answer here is that a Glomus tympanicum would classically look like a mass with a salt and pepper appearance on MRI that is confined to the middle ear, and the buzzword is that a Glomus tympanicum is positioned over the cochlear promontory. Those are all high-yield questions. In general, paragangliomas are high-yield topics for the ABR core exam. Spend some time to review these and make sure you are prepared to answer questions on these entities when you take your radiology board exams. Last and final question for this episode. What is an imaging feature that can help differentiate between a schwannoma and a paraganglioma? Compared to a paraganglioma, a schwannoma would be less vascular, therefore would typically not show the classic salt and pepper appearance on MRI. On a radiology board exam question asking you to differentiate between a paraganglioma and schwannoma, I suspect they would probably ask you about that salt and pepper appearance first, and expect you to know that if you see the salt and pepper appearance on MRI, you are going to choose a paraganglioma rather than a schwannoma. That concludes this episode. I will have an additional episode on head and neck cancers. That may also go into some of the anatomy of the spaces of the neck, which is high yield to review as well. I was told as a medical student that for those who are prepared, examinations are not a test but a celebration of knowledge. I have taken some exams in my life where I've felt that way. I certainly have also taken many other exams in my life when I have felt like this is definitely a test and not a celebration. But the point is that if you are prepared, then you will not be so stressed out and you can feel really good about how much you have learned. It is a cool feeling when you succeed on that examination. Please keep a positive mental outlook that you will succeed on this examination. I know studying can be super stressful, and I recall back on my own time studying for the examination with my co-residents, we were definitely pretty stressed out. And if you're starting to feel that way as 2020 nears an end, it is normal. The key is consistency. Consistent hard work and study will pay off in the end. So study hard, prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.